Hello, everyone, and thank you very much for joining us for the EURETINA double debate. Today, on behalf of myself and Professor Sebastian Wolf, I want to thank our speakers who will introduce two topics that are very controversial and very novel in the way we manage our patients. One is the risk benefit of the port delivery system, and the second, the difference between anti-VEGF agents in the management of vein occlusion. For the first debate, we have Professor Korobelnik debating against Professor Pearce. And for the second, we have Professor Baruch Kuppermann debating against Professor Bandello. For both debates, the speakers will be joined by Professor Marta Figueroa and Professor Usha Chakravarthy for the discussion. So without further ado, I would like to invite Professor Jean Francois Korobelnik to speak in favor of the motion that the risk benefit of the PDS outweigh in favor of using it. Jean Francois.
Yes, hello, Anat. Hello, everybody. Thank you very much for the invitation to be part of this debate. I will try to demonstrate or to illustrate the fact that, yes, the risk benefit of PDS warrants its routine use in neovascular AMD. So these are my disclosures. Okay, so what are we talking about exactly? For those who are not very familiar with the PDS, here is a picture of it. It's a device that is implanted in the eye. It's a surgery to implant the device, and it's a reservoir so that you can fill it and you can refill it again and again and again. It is done under local anesthesia. It's quite simple if you strictly follow the guidelines of the surgery, and it will deliver very slowly the drug that is in the reservoir. So to illustrate the capacity of the system to work, we have a large study that has been conducted. Patients with wet AMD were randomized to receive either monthly intravitreal ranibizumab or the PDS filled with ranibizumab at a specific concentration in the reservoir during all the study. The primary endpoint was a composite parameter made at weeks 36 and 40. So these are the baseline demographics of this study. You see that 250 patients received the PDS against 167 that received monthly ranibizumab fixed regimen. We are talking about fixed ranibizumab. That's very important. Mean age 75 years old, which is a little bit younger as compared to other phase 3 trials. Nothing specific otherwise. And you can see at the bottom of the table that the patients that were included received prior to the surgery, they received a mean number of 5 injections of anti-VEGF agents. So this is the result of the trial so far with regard to best corrected visual acuity. You see that in the group that received the PDS, there is a small decrease in vision at the first visit at 1 month that is related to some cases that had intravitreal hemorrhages, but it came back. And then it is completely stable, flat, no increase, no decrease, stable. You can see that the refill was made, it was per protocol, it was made every 24 weeks. But you see that before the refill, the mean visual acuity was absolutely stable. So obviously, it was not the end of the delivery of ranibizumab in the eye for the reservoir, but it was per protocol mandatory to do the refill at that time. What about anatomy? Anatomy is exactly stable, flat, no zigzag, no decrease, no increase. Patients were stabilized at the beginning and they were stable with regard to anatomy all along. And again, when the refill was made, there was no decrease in visual acuity, there was no increase in thickness in the visit before or at the time of refill. So what are the advantages? Well, we know from all the pivotal trials that when we do fixed regimen, we have stable visual acuity. And that's exactly what we reproduce with the PDS. We have stable visual acuity, and that's true with ranibizumab on your left, that's true with aflibercept on your right, and that's what we would like to do. But of course, fixed regimen is not at all what we are doing in the daily life because the burden is too heavy. What is the other advantage? We avoid any fluctuation in the fluid. You can see in that paper, and I'm sure that Usha will discuss that later on, you can see with that paper that with, with the patients that had very stable anatomic results, they were the best to have, they had the best chance to have maintained visual acuity. And when there is a recurrence of fluid, especially intraretinal fluid, PED, that was not good at all for those patients. So stability of fluid, no recurrence seems to be really important to maintain stable vision. And of course, there is less burden. Yes, there is a small surgery at the beginning. Yes, that's a small surgery. But after that, you need one visit 1 month after surgery to check healing of the surface, to check that everything is fine, and then one visit every 24 weeks, and that's all. So it's twice a year, and maybe it's even less because, as you've seen, it's stable at the time of the refill. So probably some patients can go longer without a refill. Twice a year for wet AMD patients. That's a dream for the patients, especially as you compare to the mean number of visits in real life in that study done in Spain, where there were, during 2 years, 16 visits. So you see that you can have 4 visits, let's say 5 visits with the PDS, as compared to 16 visits in 2 years in that Spanish study. And that's a good study because I think that it reflects the capacity, the necessity to see those patients very often, to monitor the disease and to treat very often. Of course, as always, there are small, minor disadvantages. It's a surgery, you have to go in the operating room, but it's not very long. It's 20 minutes, 30 minutes surgery, a little bit longer than cataract surgery, but not that much. You need, of course, the availability of the surgeon. You need the availability of the operating room to do the surgery. But once it's done, and the refill is done in the clinic. You don't need to go to the operating room anymore once the reservoir is in place. There is definitely in the trial a risk of endophthalmitis and a risk of dislocation, but the circumstances of those risks have been well identified, and they are probably correlated to the surgical technique, both the size of the incision and the quality of the sutures and the way to put the conjunctiva back in place with the tenon so that the device is fully and well covered. And last but not least, probably we don't know exactly the cost of the device. At least I don't know it, and I don't know the cost of the refill. That may be a disadvantage, but that may be also something positive for the patients. So at the end, I think that the risk-benefit ratio is definitely in favor of the PDS, probably to begin in a selected population that need very frequent injections after loading, and also when transportation and attendance of visits is very difficult or almost impossible. And that's, I would suggest, the case when you have wet AMD patients with a very active disease that require injections every 4 or 5 weeks. The burden is then very heavy. It's the same in wet AMD with very old patients where attending appointments and visits is complicated. And even if it's not exactly my topic, I would say that it's probably interesting to use the PDS in diabetic patients, where those diabetic patients have multiple visits with multiple physicians. They are so busy to manage everything that if we can avoid visits to the ophthalmologists, that would be probably extremely helpful. Thank you so much.
Thank you very much. And I will invite Professor Ian Pearce to to speak against the motion. Ian?
Thank you very much, Anna. If I could have my slides up now. One of the advantages of going second in the debate, you have the advantage of listening to the first debate, and we'll explore some of the words that JFK used. Small minor disadvantages. Well, let's see whether those are small minor disadvantages. These are my disclosures relevant to this talk. Now, one of the important things, I'm just going to go back on this slide in a moment. We're just moving forward on it. There we go. For some reason, there seems to be a slight delay in the slides coming back and forward. Okay, I think we're moving now. Okay, there seems to be a slight delay. Okay, so we're going to discuss the benefits and the risks. And you've already heard the reduction in the injection frequency is a significant benefit, the sustained delivery of the ranibizumab, and in terms of both functional and anatomically, and patient satisfaction as well may be a benefit. But those risks of endophthalmitis, retinal detachment, the conjunctival retraction and erosion really do exist. You've seen the results of the Archway trial, pivotal trial for the port delivery system, both anatomical and functional gains and stability. And these are extended out over an 18-month period. And this is a slide JFK showed you. One of the things with this, though, is that the vision stays stable. That's an advantage, but it is not superior. So you're not gaining any vision. You're just having a reduction in frequency. And that's important to remember. Now, you've also heard that actually you only need to refill it at 6 monthly. And the Archway trial showed that over 95% of the patient didn't need to be rescued with supplemental ranibizumab during the period of the study. But actually, if you look at the study criteria, it's not surprising that they weren't rescued. It was almost impossible to be rescued. If you look at the criteria for rescue, you had to have a 15-letter loss. Now, I suspect that many of the viewers on the call now will have probably intervened earlier than 6 months if you've had a 15-letter loss. It didn't have to be that. You could have had 150 microns gain in your retinal thickness. Again, not something that many of us would keep as a safety net. You were allowed to have just a 10-letter if you had 100 microns. But again, I don't think the rescue criteria would what we would be using in real life. And thus, not necessarily this idea that 95% of the people don't need rescuing has to be taken in context. Now, in the Archway trial, they also looked at patients' preferences, and they asked the patients, you know, you've now had the refill and the implant. Do you prefer that compared to ranibizumab? And over 90% of them said, yes, we prefer the port delivery system rather than the ranibizumab injections. But of course, this is a very biased population of patients. These are patients who are enrolled into the trial and said, yes, I don't mind having the surgery. So I'm not sure that necessarily reflects the general population we will see. So now I've taken apart a bit of the benefits and shown you some of the weaknesses of those. Let's turn to the adverse events, the endophthalmitis, the conjunctival retraction, etc. Now, if you go to the FDA label for the PDS system, so you'll know that since 21st of October this year, you can now get an FDA licensed PDF system. But it comes with a so-called black box warning. So if you go to the FDA website and find out what a black box warning is, a black box warning appears on a prescription label and is designed to call attention to serious or life-threatening risks. Now, many of us not seen this black box warning before. We don't see it with Lucentis. We don't see it with Eylea. My goodness, we don't even see it with brolucizumab and Beovu. If there was one place you'd think there'd be a black box warning, and it still isn't there. The first time we see a black box warning is with the port delivery system. And this is what a black box warning looks like. It says that the systemal implant has been shown to have a 3-fold higher rate of endophthalmitis compared to repeated intravitreal injection with ranibizumab in the clinical trials. And it's a 2% risk of endophthalmitis, 2%, 1 in 50 patients. Where does that figure come from? Well, you've got the Ladder and Archway trials, the phase 2 and the phase 3 trials. These have been extended into an extension trial with repeated refills, so-called the Portal trial. And also those patients who are having ranibizumab in those phase 2 and phase 3 trials could then, after a period, be transferred into the Portal trial, have an implant of the PDS system, and then have it refilled. And that leaves us with 555 patients who have been monitored either in phase 2 or phase 3 clinical trials over an extended period. Now, so this is the adverse events from that portal trial. And this is where the 2%, out of 55 patients, 11 with endophthalmitis, the 2%. Now, of course, there's been some elements of changes in the protocol and making sure that we make sure the subtenons is covered over the implant and the conjunctiva is sutured down to the sclera, but it was still 2% in the trials. Let's look at the rhegmatogenous retinal attachment, 0.7%. That may be acceptable, it may not be, that's up for individuals. But here's an important concern. Conjunctival erosion, 4%, and retraction of 1%. It's a significant number of patients we're going to need to monitor. And even if you get away with that, with the implant refill, there's a 1% chance of dislocating the implant into the middle of the eye. So serious concerns that we have to be aware of. Now, here's basically a breakdown from the portal trial of when these adverse events occur. And you can see of particular note is the conjunctival erosions. We're looking at somewhere 3 or 4 years down the line. So you implant, you get a bit of benefit at the bottom, but you've got a 4% chance of erosion and retraction as we go long term. And Genentech and Roche have worked very hard to address this, and this may well reduce with time. There are also unknown adverse events. What about the potential to promote atrophy with these patients? We saw that in the meta-analysis of the continuous arms in the CAT and IVAN trial, the potential for causing increased atrophy. Will that be a problem? The effects on the corneal endothelium. Now, I didn't think this was an issue. However, in the post-marketing label for the PDS system from the FDA, they've specifically asked for a controlled clinical trial looking at endothelial cell counts. Now, I can't find the underlying reason for that, but they felt that it was serious enough to demand that as part of the post-marketing surveillance. But the biggest issue to the routine use of PDS is the benefit of other agents. We've got faricimab here, Tenaya and Lucerne, showing 80% of patients receiving injections at 3 months and 50% of patients at 4 months. You've got the Kodiak trials coming in closely on the rails. You've got the KSI 301. This is the phase 1 results, but there are phase 2, phase 3, hoping to report very soon, showing 2/3 of patients out at 6 months. Now, the Genentech and Roche they realize that 6 months is not a safe bet. They need to extend it, and they've developed the Velodrome trial to address this with 2 arms of the trial with maybe a 6-month compared to a 9-month refill. And we'll have to wait to see the results of that Velodrome trial, which is presently recruiting, to see whether we will get out to 9 months with a refill strategy. So we've seen the benefit of risks. And so the question, the debate is the risk-benefit ratio, the PDS, warrant its routine use? This debate is the routine use. And my answer will be no. We will consider it routine when the endophthalmitis rate is lower than 2%, and the conjunctival retraction erosion issues have been solved to a long-term basis. And there must be clear water between the available newer agents that we're faced with at the moment, between 4 and 6 month durability, and the present 6-month refill capacity for the PDS. We really do need to have that out to 9 months and clear water before we can consider it for routine use. At the moment, I would consider it for selected cases with well-informed patients aware of both the short and long-term risks. So I'm sure you'll agree with me that it's only right to vote against the motion for its routine use in neovascular AMD. Thank you.
Thank you very much, Ian. This was very interesting, Jean-Francois, and both have good arguments. May I ask first, Marta? Marta, do you have experience with implanting this device? You are a very experienced surgeon. Have you done it? What's your experience? You're muted.
Yes. I personally have no experience, because I did not participate in the Archway study or the later study. I tried a prototype many years ago, and it's very similar to what is used right now. And I think it's could be a very useful device. There are some, complications, as Ian mentioned. But I think that little by little, we are learning more and more about how to resolve or how to reduce the risk of these complications. So it has been said that the conjunctival manipulation has to be very gently, and the closure of the conjunctiva and the tenons has to be very, exact in order to avoid the retraction or the conjunctival erosion. And this is very important, but also it's very important the size of the incision.
So can everyone do it easily, Marta, or do you need a lot of training?
I think it's very easy for a vitreoretinal surgeon, but there are some tricks. And the tricks are the conjunctival manipulation, the conjunctival and tenons suture, as well as the scleral dissection size. These are, from my point of view, the most important steps to consider in trying to avoid or reduce the risk of these complications.
So, Usha, what's your feeling about this? I know you may be concerned about atrophy development and continuous VEGF suppression. Any thoughts about this?
Sorry, Ian. So Sebastian, I wasn't sure that you were addressing the question to me. Yes, I mean, the thought of continuous suppression, but on the other hand, it's worth realizing that with bolus doses, when you kind of put a large amount of anti-VEGF in at any one time, and you have the sort of fluctuations in the concentration of drugs in the vitreous, there's potential for harm that way too, because you might be inhibiting all VEGF for a period of time. And then if you think about any protein and its ligand interaction, you could have a situation where the ligand is completely inhibited, and then the moment the levels go down, the ligand becomes the receptors overexpress themselves. So there is potential for sort of ligand receptor interactions, which we don't fully understand. But Sebastian, may I actually ask the speakers a couple of questions from their viewpoint, if I may?
Yeah.
So I want to ask JFK, would you be prepared to leave a patient for 6 months on the basis of what you've learned from the clinical trials? I mean, these clinical trials watched their patients every month and made decisions every month on whether they needed rescue or not. Would you be prepared to just leave your patient for 6 months on the basis of what you've learned?
Yeah, that's a good point, Usha. But look at the visual acuity. If there was under treatment because the criteria that Ian mentioned were too large, visual acuity would go down. And of course, it's a mean, but visual acuity is really completely flat and stable. So it makes me quite comfortable to believe that probably it's safe with regard to the disease activity. Yeah, I mean, I consider, well, you heard me. I consider a routine use in a selected population of patients.
And I have a question for Ian. So Ian, we know that the risk of endophthalmitis after vitrectomy, the much more severe surgical procedure than sticking an implant in, ranges from about 0.04 to 0.02. Doesn't this sort of tell you that putting a PDS implant in was taken maybe sort of in a very blasé manner initially by the surgeons, and they didn't take as much care at the start because they thought, right, this is just sticking stuff in, we're not taking any vitreous out?
Yeah, I wouldn't be as bold to say they were they weren't being cautious, but I think there have been learning aspects all the way along the evolution. And I think, although I was asked to speak against, I do think Roche and Genentech have made a very professional approach to this delivery system. They're looking and monitoring very closely. They're videoing the techniques. They're looking back whenever these cases, there's a deep dive and trying to approach them. So I think that, as Marta's already suggested, the attention to the conjunctiva, making sure we get that conjunctival coverage over, is critical. I think the other thing that they're doing is they're monitoring the patients over a long period. I mean, these extension studies are critical for us to understand the longer term risks and benefits. And one of the things that, if I was speaking for the motion, I would say that, you know, when we're looking at over 18 months, 2 years, yes, we'll get stability. It's stability at 3, 4, 5. I think hopefully the PDS system will allow us to have that stability over the longer term. And I think things like the portal study are allowing us to monitor that over the long term will benefit. Vitrectomy has a lower incidence of endophthalmitis because you're taking the whole of the vitreous out and probably improving your response to any microbes inside. So, but I think the one big thing that worries me is little old people have very friable conjunctiva. I think JFK alluded to it. They were an earlier age group, 75-year-old these. Well, a lot of our patients are 80, 85, 90. And as soon as you pick up the conjunctiva, it dissolves in front of you. And how do you predict those patients? I think is going to be our biggest challenge. And we're going to have to learn from our glaucoma colleagues about how to assess the conjunctiva, because we really need a good Tenon's coverage. We don't want to find that out with the operation.
There was a question in the audience if you do a fornix-based flap or in the cornea-based or limbus-based flap, if there is a difference in the rate of retraction. And I don't know who has experience from us to implant it. Baruch, do you have experience? Have you done it or haven't you?
So great debate. Interestingly, we had a similar discussion yesterday in a separate conference with Arshad Karnani, who has done these, and he's in Reno, Nevada. He was one of the investigators. I've not done it myself, but he was not only an investigator, but he has started to do them commercially now in the United States. They're now available. And that's the big learning curve. I mean, I think it looks very effective. I think Usha's point that you asked her, Sebastian, about GA, we'll have to learn. But the biggest concern is the safety of the incision. Everything has been discussed. It's been very appropriate. And the concerns that we all share. There is no data about fornix-based flap versus limbal flap, with the caveat that what Arshad, who has done a number of these, says is that basically we have to treat conjunctiva now, not like retina specialists, but like glaucoma specialists. It's a whole different ball of wax, to use that American term. So it's a learning curve that we'll learn. And the risk is significant. If you look at those percentages of endophthalmitis, they're non-trivial. They're quite a bit higher, and they're associated with conjunctival erosion to a high degree. The caveat is that a lot of those in the clinical trial were based on an older methodology, and they've since updated the procedure, and their data is now better. But the marketplace will help us determine this.
Yeah, just a short comment.
Sebastian, Anat, may I address a question to the speakers? So my question is, we spare a lot of injections, for sure, doing the PDS and refilling of PDS. But I really would like to know how long is the procedure and how many injections you could perform on the same time. Because we say there is a risk, a great advantage from time sparing, because you are avoiding a lot of injections. But the point is that whenever you are doing this procedure, you are spending a lot of time compared with the injections time. So are you really sure that this is useful for at least for this respect? I'm not speaking about the bother for the patients and so on, but with specific reference to timing. What do you think about that?
I can start to answer. I think that the burden is the injection. I agree with you, Francesco. But for the patients, the burden is everything else. So transportation, waiting time in the clinic, availability of a family or someone that is going to drive them back and forth.
No, but JFK, I'm not speaking about that. I'm speaking about the time that you are sparing with PDS procedure compared with normal injections. That's my question. I'm not sure that we are sparing time with the PDS. That's the point.
If you consider medical time, I agree with you that doing one PDS procedure, you will do, I don't know, 5, 8, 10 injections.
So
Meanwhile,
At least.
more
And if you use fixed treatment, you can do examinations only every 6 months, and you're very close to this.
but you have still the burden to the patients.
I'm
Yeah.
going to
Can I
quickly
just add? Oh,
join
sorry.
in and say that in terms of footfall of patients is also something to consider from a delivery point of view. Somebody who had to organize a service where you had thousands of patients coming up, you know, having that footfall through the clinic is also very tiresome and very expensive.
And I would also add,
So
though, that there's no indication for having the patient only come in every 6 months. You would theoretically re-inject every 6 months. Certainly, when I start, I will probably try some of these. But you know, we're all going to get experience over time. I'll see the patient probably back every month at first, then every other month, and every 3 months. I don't think there's any proposal ever for me to think that I'm going to be comfortable seeing a patient every 6 months. Probably the most that I'll extend them to is every 3 months to monitor the situation. We can monitor as often as we want.
Yes, Barry, but this is until you see that it can even last longer. So at the beginning, we you know, skeptical and just trying to check our patients very frequently.
So
but then I hope that the device demonstrate, and maybe in the future even better, that we can see our patients every 6 months. That would be great. I think it's a great idea to have something that induces a sustained delivery of a drug that reduces the burden to our patients and their families, because this is really hard for them.
So I'm very sorry. I think we have to close this debate now. That since we have another debate, we could discuss another 15 minutes, I'm sure. And I think Marta summarized it very nice. So it would be very good to have a device which delivers continuously, which is safe, which is easy to implant, and which is as effective as intensive monthly or bi-monthly or 3-monthly treatment with other drugs. So thank you, Jean-Francois. Thank you, Ian, for these fantastic debates. Then we are going to the second debate. And Anat, can you introduce the second debate again?
Of course. So now for the second debate, the first person to speak in favor of the motion of a difference between the different drugs for retinal vein occlusion, stating that all anti-VEGF drugs act the same. In favor of this motion, we will invite Professor Baruch Kuppermann to give his talk. Barry?
Hello, my name is Barry Kuppermann. I'm chair of the Department of Ophthalmology and director of the Gavin Herbert Eye Institute at the University of California. It's my pleasure to participate in this EURETINA debate. I'll be discussing in retinal vein occlusions, all anti-VEGF agents act the same. I have the pro position. Here are my financial disclosures. We know that the pathophysiology of retinal vein occlusion is complicated. It involves vein occlusion leading to retinal hypoxia and ischemia, cytokine and chemokine release, including VEGF as well as many others, followed by increased vascular permeability and macular edema. We also have clear evidence that VEGF levels are quite elevated in patients with retinal vein occlusion, as you can see here, when BRVO on the left and CRVO on the right. Furthermore, we know that there are many cytokines that are released, many interleukins, the monocyte chemoattractant protein, but VEGF is a key component. You can see here for diabetic macular edema, comparable levels are seen for branch retinal vein occlusion, and for central retinal vein occlusion, it's quite markedly more than that, almost tenfold. So the treatment options for RVO have been long established. Anti-VEGF agents are shown to be safe and effective, including bevacizumab, ranibizumab, and aflibercept, and I'll show you data about that. Corticosteroids have also been shown to be effective, but less safe because of the known side effect profile. Focal laser and sectoral or full PRP are also employed. The structural design of our current anti-VEGF inhibitors that are used commonly are as follows. Bevacizumab, we all well know, full-length monoclonal antibody, 149 kilodaltons. Ranibizumab is the FAB fragment of 48 kilodaltons, and aflibercept is the fusion protein that not only is a VEGF-A inhibitor, but also as a placental growth factor inhibitor, and that's 115 kilodaltons. So there's ample data to say that all these agents are individually effective. Bevacizumab, of course, is off-label, has many smaller studies, 60 patients in this study with central retinal vein occlusion, randomized to sham versus bevacizumab every 6 weeks. After 12 months, we saw 60% of patients gain 15 letters, and there's no in 15 letters. If you look at the branch retinal vein occlusion pivotal study for ranibizumab, the Bravo study, you can see the design, monthly injections for first 6 months, followed by PRN treatment period. For central retinal vein occlusion, the same design, the Cruise study. And finally, there was a follow-on study for a second year of the Horizon study. And what that data of those studies shows that in the branch retinal vein occlusion study, 19 letters gained in the first year, maintaining most of that in the second year with Horizon, 17.5 letters gained. For Cruise, 16.5 letters gained for CRVO after 1 year, a decrease down to 12 letters gained after the second year with Horizon. And if you look at the percentage of eyes gaining 15 letters for branch retinal vein occlusion, slightly over 60% first year and 60% the second year. For central retinal vein occlusion, 59% the first year, dropping to 45% the second year. If you look at OCT thickness, it's remarkably effective, as we well know. And both branch retinal vein and central retinal vein occlusion, from a safety standpoint, adverse events in the study eye are well known and are typical of most injections. If you look at systemic adverse events, there's nothing that pops out, and it's comfortable to say that it's no significant findings, but again, these are all underpowered to show differences. If we look at aflibercept, again, a similar study design. Copernicus and Galileo had slightly different designs, but basically, first 6 months were injected regularly, and then crossover. Then there was a PRN phase thereafter. Galileo had a different sham than Copernicus. And again, you can see the data here. The gain of 55% of eyes gained 15 letters. In Copernicus, 60% in Galileo. And if you look at the letters gained, 16 letters gained versus 17 letters gained in Copernicus and Galileo. Again, great control of OCT thickness. From a safety standpoint, similar, nothing really pops up. And again, the APTC events are well known and rare events. Now let's go to the really matter at hand. The comparison study, SCORE2 compared aflibercept to bevacizumab in CRVO patients. The bevacizumab patients gained a mean of 18.6 letters, 61% of them gained 15 letters. The aflibercept group gained a mean of 18.9 letters, 65% gained 15 letters, very comparable results, showing that bevacizumab is non-inferior to aflibercept. And you can see here the OCT results from the SCORE2 trial. We now look at the BRVO study, which is named, but includes BRVO and CRVO patients. 139 were treated with bevacizumab, 138 with ranibizumab. The bevacizumab group, 15 letters gained, 69% gained 15 letters. Ranibizumab also 15 letters gained, 64% gained 15 letters. No significant difference in OCT thickness. The results show that bevacizumab is non-inferior to ranibizumab. And here you can see the curves of the visual acuity gain and the OCT thickness resolution. Finally, the more confounding one was the study that compared bevacizumab to ranibizumab to aflibercept in 463 patients with CRVO. Ranibizumab, 12 letters gained, bevacizumab, 10 letters gained, aflibercept, 15 letters gained. You look at the 15-letter gain percentage, 47% for ranibizumab, 45% for bevacizumab, and 52% for aflibercept. This showed that aflibercept was non-inferior to ranibizumab, but bevacizumab had that difficult, non-inferior double negative to ranibizumab and aflibercept, meaning it may or may not be worse when using bevacizumab. But if you look at the actual data, you can see out through 76 weeks, there's no differences. There's a bit of a spread in the last bit of the study, and OCT thickness looked quite comparable between all three groups. In summary, to ask the question, are all anti-VEGF agents the same for RVO? The answer to me is yes. Bevacizumab, ranibizumab, and aflibercept are all shown to be safe and effective. In individual trials, the two critical comparison trials, SCORE2, showed no difference between bevacizumab and aflibercept for central retinal vein occlusion. The BRVO trial showed no differences between bevacizumab and ranibizumab in anatomic or safety outcomes as well as visual acuity. The HICAN trial did show some differences, but they're ambiguous. According to the transitive property, if A equals B, aflibercept equals bevacizumab, and if bevacizumab equals ranibizumab, therefore aflibercept equals ranibizumab, therefore they're all equal. All anti-VEGF agents are the same for RVO. Thank you so much for your attention. I appreciate it.
Thank you very much, Barry, for this very convincing motion. And against the motion that they are equal, namely saying that they are not equal, I'm inviting Professor Francesco Bandello. Please, Francesco.
Thank you so much. I'm really sorry I do not speak very well English, because I wanted to answer to Barry, to the last sentence by Barry, in this way, but I'm not sure I'm able to make you understanding me. So when I studied philosophy and Aristotle, you know, the syllogism was the way of thinking of Aristotle. Are you understanding me? Yeah. So when you say the small salt fish causes you that you would like to drink a lot. If you drink a lot, you are able to feel no thirsty. And therefore, the small salt fish are able to make you not thirsty. Are you understanding me? You do not need to drink thanks to the salt fish. That's your way of thinking, Barry. That's you were saying this is similar to that, and therefore I can go to the end of the problem. That's not the way, because there is a problem in this way of make syllogism. But I'll try to answer you now. So these are my disclosures. So the importance of the epidemiology, I think it's not a hot topic for us. What I like to remember first, and I think this is really something that we must remember, is that retinal vein occlusions, and particularly central retinal vein occlusion, were completely different before the advent of the intravitreal therapies. I think that more than diabetic retinopathy, more than other diseases, the advent of intravitreal therapies made the treatment of our patients much better than before. We had nothing before. We were speaking about some grid treatment for the macula with the age more than 40 or less than 40. The central retinal vein occlusion study was crazy. We had nothing. And after the advent of intravitreal therapies, everything changed. And anti-VEGF as well as steroids made really the difference. So at the moment, we can use ranibizumab, aflibercept, bevacizumab, and maybe in the near future, brolucizumab. And, you know, Barry told us already the main results from the Bravo, the Cruise, the Vibrant, Copernicus, Galileo, and so on. And all these results were based on the use of the anti-VEGF principle. And with reference to ranibizumab, we had that after 6 months, there was an improvement of 18 letters, so really a lot compared with 7 letters in the sham group. And for the Cruise study, the improvement was 14.9 versus 0.8. So the change that we had was really something important. It was a revolution, if you remember what we did before. And also after longer follow-up, it was shown by the RETAIN and the Horizon studies that it was possible to maintain the improvement in visual acuity. And maybe this is the field where the improvement we have is staying at the same level for longer time compared with diabetic retinopathy or mainly age-related macular degeneration. Similar results were obtained by aflibercept, and that's the reason why Barry was able to say, okay, they are the same. If you look at the number of lines and number of letters gained, really the results are similar. And the Copernicus and Galileo after 6 months showed 17 letters improvement. So we are more or less at the same level as the one presented before by Barry. What about bevacizumab? Also, bevacizumab showed some improvement, some significant improvement in visual acuity. Maybe the results were not at the same level of scientific power, but they were able to show that also bevacizumab was able to produce good results. But the main difference, at least from my point of view, is based on this study where some of the speakers today were the authors, and this study was able to show, comparing one different options of treatment, they were able to show that the difference is there. There is some difference, at least. You see that always the patients treated with aflibercept showed some improvement compared with ranibizumab and bevacizumab. It was true for visual acuity, it was true for the retinal thickness, and it was shown for the number of injections. And this is after 24, 52, and 100 weeks. So for sure, the results are similar. For sure, the differences are not so important, and all the anti-VEGF compounds are effective, but it's evident that some difference is there, and we must consider that. We do not know at the moment anything about brolucizumab in patients with retinal vein occlusion, but we have 2 ongoing trials, and whenever the results will be available, I think that also in this case, improvement will be clearly shown. So in conclusion, we have different agents with different structure, and all these drugs are for sure effective, and all the trials done till now have shown that this is an important tool for treating our patients with retinal vein occlusion, but some difference is still there, and we can consider different drugs for different patients, because I think that some difference must be considered well evident. So thank you so much.
So thank you, Francesco. Thank you, Baruch, for these convincing talks. Very difficult to decide. We are in the happy situation that Usha is with us, and Usha is one of the authors of the trial comparing the 3 drugs. So Usha, what's your perspective of your study? Is it really like Baruch was telling no differences, or like Francesco is telling big differences or some differences? What's your approach?
Well, it's a very good question, Sebastian. I think that the data that we have with regard to durability and efficacy of these different agents does suggest that the latter agents, as ranibizumab and aflibercept, have perhaps a better neutralizing ability to bind VEGF, and as a consequence have perhaps better durability and perhaps better disease control.
You're always using this word perhaps. What does it mean?
Perhaps, well, because we have not tested it. I think we need to do things like we need to change the way in which we analyze these data. We need to do time to event analysis. At what point in time does the fluid disappear? What point in time does disease activity reduce? So these things have not been done with these data sets, and it's time we sort of moved away from just looking at visual acuity and looking in a more systematic way at disease activity parameters, but we need agreement on what constitutes these parameters, and I don't think we've reached that yet. So,
can I elaborate on Sebastian's question to you for a second, Usha?
Yeah.
Can you maybe elucidate our thinking in what, because there are 2 studies that say different things, the SCORE and the LEVO. What is the reason for the difference between these trials?
It's hard to tell, but I'll tell you what, the studies were not contemporaneous, so you might be enrolling different patient subsets. LEVO was indeed the largest trial. So, the greater the sample size, the more likely you are to show these differences. So my guess is that in Levo, the fact that bevacizumab performed least well is not that surprising.
If I can add as well, Usha, again, I agree with all your comments. I would just also point out, at least in the Levo study, if you look at the other time points, the spread only happened latest. If you looked at, I would guess, I have to go back to think if the paper said it explicitly. If you did a statistical analysis at all the other time points, I believe that none of the three were different from each other. It just was at that one time point. So I think we always have to be careful about the final efficacy endpoint, looking at that as a sole point in time as well as instead of the totality of the data. But that being said, I will agree with you in many ways that it feels a bit like for neovascular AMD, the differences between the three agents are minute. When you get to retinal vein occlusion, there may be the beginning of a slight spread. And by the time you get to diabetic macular edema, I think there are greater differences. So these three disease states are different from each other. These are all amazing and effective agents. We're grateful to have them all. We wish that brolucizumab was a little safer because that would have been a great addition to our armamentarium. But I think there is, with retinal vein occlusion, I think is the great debating ground. That's why I think this is a great choice, because it's right on that knife edge. Diabetes, I think, aflibercept is, to me, stronger maybe even than ranibizumab, but they're both better than bevacizumab. For AMD, as you've shown and others, not much difference. Retinal vein occlusion is, we're almost debating that, Angels is on the head of a pin. It's the differences are beginning to appear. They're minute, but there.
Anyway,
Marta, do you have any thoughts about this?
I like to say, Barry, the right translation. The salty sardine makes you drink and drink. The drink and drink quench your thirst. Then the salty sardine quenches your thirst. That's the way you presented the data before. Be careful.
I just want to know if I'm drinking wine or water. That's the important part. That's what I want to know.
So, Marta, which drug are you using? Do you see differences? Are you using them differently?
I think that in retinal vein occlusions, the difference is not as important as in other diseases like AMD or diabetic macular edema. So that's why I would like to ask a question to Usha. Usha, if you have to choose what is more important in retinal vein occlusions, is the drug or when and how you treat it?
I would say it's when and how you treat it. The sooner you treat it, the better. So the earlier you treat it, the better. There's no doubt about that. And patient management sort of, and in fact, I mean, I know that in my clinical practice, quite often when I would give an anti-VEGFs and then I would plug in an Ozurdex to get it and give, and that made a huge difference. So, I'm not sure that I totally agree that that all anti-VEGFs are the same. I'm not, but I also think that combination therapies, and I also think that laser photocoagulation is something that one shouldn't forget about, because you can, for BRVOs in particular, you can ablate the anoxic retina and you can give the patient months and months and months of appointment free and at times. So we've taken the easy way out. We've delegated all these things to our nurses, and we just get them to inject all the time. And I think that's a pity.
Yeah.
We have a question from the audience or a comment from this. So Shova is giving us some information that bevacizumab had in this study significant more fluid and dry time, so more differences. And she's saying that this is not as good as having constantly dry retina. Usha, could you confirm this? Is this a driver of the small difference you see in the study?
Could well be, indeed. And one of the things that you observe is that you don't really see the same effects that you see in clinical trials when you take it out into the real world situation, because I think that the patients are so different You exclude a large number of patients. If they've got hypertension, if they don't want to come, they're very elderly patients. There's so many things where you just exclude these patients. So you get a very sort of more homogeneous population when you put them into clinical trials, whereas when you start treating patients, they're much more heterogeneous, and that's when you have to be really on your toes and how you manage them.
That's a good point, Usha.
Baruch,
Sorry, the treat and extend does give us that ability to really titrate these patients quite accurately. And I think it is true, back to Marta's comment, on treat and extend, even though the outcomes are good for AMD for all three, the reality is in general, the durability in most patients, not all, tends to be greatest with the aflibercept. And Ian had a question in the chat about faricimab. That data looks very promising. I didn't present it here, but again, faricimab with its action that we're seeing may be the new leader in the field if and when it turns out to be safe and approved. But we're excited about the future.
Provided it turns out to be as safe as the rest.
Correct. That's the big fear, is the safety. And brolucizumab burned us all, and that's what led to abicipar not being approved as well.
Yeah, and my understanding is
faricimab looks good so far.
Yeah. So what drug would you use yourself if you would have a retinal vein occlusion, Baruch?
I tend to be I use a lot of aflibercept, honestly. To a certain extent in the United States, we're guided by the restrictions of the insurance company. Sometimes they have what's called step therapy, where you have to start with bevacizumab because it's less expensive, and then you're allowed to migrate to other drugs based on certain criteria. Most of my patients don't require that. When I have free choice, I tend to use aflibercept more than the other therapies, but I move around.
Francesco, what would be your choice?
Maybe aflibercept, really. And what I like to underline is what was saying Usha before. It's very important timing. From the first study with Ozurdex on retinal vein occlusion, we discovered that it's important to start to inject as soon as possible. And this was not what we knew before. It's completely new information, because I remember when I was young, I was studying that you had to wait 6 months before starting any treatment for retinal vein occlusion, waiting for some kind of collateral vessel that could be useful to improve the situation. This was wrong. And we discovered that thanks to intravenous injections.
I think it's very interesting that both discussions, both debate participants, one for pro and the other for against, would choose the same anti-VEGF drug for their own treatment. So this means they have a preference, and this seems to be when there could be a small difference. So
at most a small difference, but you're well pointed. And by the way, Francesco, part of the rationale was, again, as you point out, the natural history back in the day, but that was because the only treatment we had was laser. And once a laser spot is placed, you can't ever take it back. Whereas an anti-VEGF injection, you can give one and not give any more if not needed. So that was that ability. And Usha, when you say use laser, are you referring to sector PRP, not macular laser?
Oh, yeah, no.
All of us have those macular lasers that we did 20 years ago, and they looked great 20 years ago. Now those tiny little spots have spread into
we hate them all today.
Yes. We're talking purely sector, and particularly if you've got an inferior BRVO,
Yeah.
Sure.
Okay. So I think the time is coming to an end, and I would like to ask Anat to give her final summary or comments. Anat, you're muted.
Thank you very much, Sebastian. I think those were two excellent debates on very hot topics, basically dealing with how to best manage our patients. And I would like to thank the speakers for the excellent talks. Each of them was really convincing, and the panelists and my co-moderator, Professor Sebastian Wolf, for leading the discussions, and the panelists for excellent discussion, and the audience for attending. Thank you very much, and we will get back to these topics in future debates.
So thank you so much.
Bye-bye.